We continue on toward our holiday season, and it's supposed to be cold outside. I'm here in Michigan, and it's actually 50 degrees outside today, so it's kind of an unusual day. Speaking of unusual, I'm sure if you've looked at the number of slides that we have, you're going to be nervous that I'm going to get through all the material. But as many of you know that have heard my presentations before, especially on an updates lecture like this, one of the things I want you to do is to have the information. And so in many instances, there will be slides that may be, for example, a slide that has a picture of something out of your CPT book, just so that you can know what it looks like. And so many of the slides are just for your reference. I won't be reading slides. I won't be, as I hope that's an okay thing for you, I'm not going to be reading my slides, but rather I will go through the material in a conversational manner and allow you to learn, but you also have the exacting words of the guidelines. We have lots of codes that have very large amounts of guideline changes, and those are very important to pay attention to. Lots of times as a consultant, when I get questions, I'll say, well, what did the guidelines say? And they'll go, well, what is that? And I'm like, well, you go to your CPT book and then you go to the beginning of the section, and here we have this phenomenal resource. So having said that, do not be intimidated by the fact that we have a fair number of slides to get through. In November of every year, there is a meeting, usually in Chicago. Unfortunately, for the last 2 years, we've been virtual, but it's the AMA Symposium. And at that meeting, the AMA presents all of the new codes, which is what this lecture is about. And they have speakers from physicians speaking on that specialty to Medicare MAC medical directors that will comment, what is Medicare going to do about that? We were presented with this Y modifier. So the good news is we have a modifier for this synchronous telemedicine service, but we haven't seen how we're going to use it. We haven't seen who's going to use it. And so kind of pay attention to anything you see about this modifier. Now it makes sense because it's a great modifier. It's going to allow our payers to collect data on these audio only services so that they can, look at the data, perhaps adjust their policies, allow for a visual of how many patients are actually getting this particular kind of a service, and also, in essence, allow them to just look at it in that previously they would only be able to find these kinds of cases on randomness doing audits. And so this Y modifier will give them very specific information if and when we start to use it. The other thing I wanted to say before we get to all the updates, because I've gotten a lot of questions about it, is last year they came out with this 99072 code, which is for, in essence, overhead costs because of the pandemic, because of the PHE. So this is the PPE, if you will, expense code. Medicare didn't allow payment for it, and so many payers have followed suit. I know there's maybe one or two that pays some, but certainly not a lot. The RUC continues to work, and the RUC is the organization through AMA and CPT, AMA and CMS that prices things, and they've continued to work with a bunch of specialty societies in order to try to convince CMS to have some RVU assignment for this code so that it would sort of be more likely to be paid, certainly by Medicare, and if Medicare pays, it would follow with other people. There's a new section called digital medicine. And unfortunately, I put a slide in the wrong place. So I'm going to just go forward for a minute, because there is now, there it is. There is now an Appendix R, and this appendix is an appendix for digital medicine. It's been added to the CPT code set to provide a taxonomy of digital medicine services. It classifies existing CPT codes that describe digital medicine into discrete categories that are then organized by the provider of the service, the activities involved, and the clinician work. It's a rapidly growing field, and so as they become more sort of just out there, it'll give us a way to look at where are all these codes, where can I see them in one single place and compare and look at them. So having said that, so that again, as I said, was in the wrong place, but we'll go back to the beginning so that now you know what digital medicine is. So we have a new code or a new set of codes for remote therapeutic monitoring service, as opposed to this is RTM, as opposed to RPM, the programmable. We have the first difference between these two sets of codes we see is what are we monitoring? So the RTM, these codes don't monitor health conditions. I'm sorry, they monitor health conditions, but they monitor like the musculoskeletal system status, the respiratory system status. So compared to the RPM, these codes offer a whole different allowances of applications with patient care. Now, what we're looking at is what clinical use are we looking at? We have some supply codes that are very similar to the RPM codes, but not exactly. And then we have, we're looking at specifically the respiratory system and the musculoskeletal system. That is how these codes are set up as of right now today. And then they both are looking at a medical device. And as we know, that medical device, see, it's on the next slide, has to have, let me grab a pointer here, has to have FDA approval. In the guidelines, we see the timeline, 30-day period, has to be ordered by a physician, et cetera, et cetera. So there's all the guidelines, the kinds of things I'm talking about. I'm not going to read. There's information there. I've tried to kind of underline the important parts, if you will. And then this 98975, again, part of the guidelines because it's got this green ink, first of all, and just a reminder, these green sideways triangles mean we have new or revised text. And then if it's in green, that reminds you it is text. So here, this is revised text, these two lines, or new text. The red dot means we have a new code. So here are our new codes for remote therapeutic monitoring. We have our initial setup and patient education, and then the device. So basically, here's for the care, and here's for the cost. And then this is for the musculoskeletal system. The previous one was for respiratory. So what we do is we have our physician or other qualified healthcare professional will be eventually using the results of these remote therapeutic monitoring to manage a patient for a specific treatment plan. So as we look at these codes, so now we're under remote therapeutic monitoring treatment management codes. So we're looking at different codes that can be reported in some instances during the same time as others, remembering that we can never count the same minute twice, so to speak. And then here are some additional rules in the guidelines. Remembering for these codes, we have a 20-minute code. You have to get to the 20 minutes. It's not a halfway code. You have to meet or exceed. And then this slide is telling us don't count any time when we have this, overlap of services. All right. More guidelines. All that, I call it green ink. And then here's the codes for remote therapeutic monitoring treatment. I love the parenthetical notes. They're so helpful, telling us, okay, we're going to report this every 30 days, regardless of the number of parameters monitored. Don't report it because of this. Don't report it. Use this in conjunction with that. I can't tell you, for those of you that are a little bit younger, having this information just is phenomenal because it sort of tells the guidelines for that right there in front of you. Now, for those of you that remember that there are certain classifications of surgeries like immunizations, like preventive care, that have their own sort of internal set of Medicare rules. These remote monitoring codes cross over the line of a couple of types. And so Medicare is struggling. The codes were really created for providers that can't bill for an E&M service because the RP, as in Peter, or program, the RPM codes are sitting in the E&M section, which means they're for physicians and other qualified healthcare professionals. These codes are sitting out in the back of the book in the 90,000 series, which means they're inherently for other providers like physical therapy, but the physical therapists are in a strange place. So this is the information that was on CMS in the final rule about these codes. I'm going to let you read it and decide how it affects you. To me, I don't understand what their problem is. I do on the one hand, I don't on the other. I think it's awfully vague, and so I put it in there for completeness, but I can also say, look at this and tell me if it affects you. If it doesn't, then don't worry about it. Now, the other thing we'll talk about is we have a lot of Category 3 codes. Category 3 codes are T codes. I call them Pinocchio codes. I say that because these codes want to be used, they want to be loved, they want to be recognized, and if they do, they become a real code, a real CPT code, a Category 1 code. So if people use these codes, then they sort of say, okay, you know, we can make it a real code, invest in going through the whole process, pricing it, et cetera, et cetera. These codes are generally not priced. These codes generally don't have a payment. That doesn't mean they can't. It just means that they have had a code assigned for something like emerging technology, to allow for people to see, okay, is this something we're going to need a code for? And if so, this is sort of the trial. So remember my little Pinocchio codes. So these codes are for this remote cognitive behavioral therapy services. As you can see with some of the codes, we have it, it's for every 30 days. They've added to report remote therapeutic monitoring of a standardized online digital cognitive behavioral therapy program. So lots of good information there. And then on the next slide, we see the actual codes. We see that we've got supply and technical support for 30 days, and then in management services by our physician or other qualified healthcare professional per month. There's the time frame. And then codes that we're not supposed to report it with. We already talked about this appendix. So now we come to the most popular topic in the world, it seems, vaccines in immunization administration. I think it's rather timely I'm talking about this because I just got a call, I volunteer. I just got a call because of the CDC saying people should get their booster, and because we just added kids to the mix. We have a local Sears where they're using the car bays to do immunizations, and I just got called to go to work as soon as I'm done with this lecture. Now, we don't bill for those services, but I sure know how. And it's kind of fun having worked it, I see it in a different light. So when we look at the coding structure, all of these codes have come out just since last year. What they've done is, to me, something just really smart. They said, okay, the vaccine or the serum, okay, the liquid, if you will, that you're going to give, we're going to make the last two digits unique to the manufacturer, unique to the specific vaccine serum. And then those same two digits, we're going to see as the second and third digit in the vaccination administration code. So I can look at any administration code and I can tell you not only who the manufacturer is, but I can also tell you, because of the last two digits, which dose it is. So pretty cool, huh? So here's lots of rules reminding us, okay, you're not going to use these administration codes when we're talking about our coronavirus vaccination. Lots of other rules about first dose, second dose, the mentioning of Appendix Q. And so here, and I only put one up because I think after you see one, you will understand. So here is the serum, the 91300. So that 00 is unique to Pfizer, to this type. And then our first dose is always a 000, which matches up here, which tells me it's Pfizer. And then 1A tells me it's the first dose, 2A second, 3A's third, 4A's booster dose. And so I can look at this and say, cool, I know exactly what this is. Now, just a refresher, the hashtag sign or number sign is telling us that this code is out of sequence in your CPT book. The lightning bolt sign means that this code, this serum was not approved by the FDA at the time the book went to press. And so they have to put a lightning bolt there to say, okay, when we went to press, it wasn't approved. You can go on the AMA website, type in this code, and it will come up and tell you when, in fact, it was approved. And then there's our red dot reminding us that we have a new code. So here's Appendix Q. So imagine Appendix Q, this book went to press when? Because look, we don't have a we don't have a third or a fourth dose of the 91300. So what I have done is you can go out on the AMA website and download Appendix Q and put it in your book. I actually took little sticky notes like the tabs and I put them on the page. So 91300 has one that has 4 different numbers on it because there's 4 different doses to give. The nice thing about these grids is it gives the NDC number, it gives a reminder of the dosing interval. How often should we get these? You can also just go on the AMA website to the Find Your COVID Vaccine, and they will walk you through some questions and tell you what your code should be. And then here's our vaccination code for children 5 to 11. We have some other new vaccine codes, again, weren't approved at the time that this book went to press, but it's a pneumococcal conjugate vaccine with a 15 valent, one with a 20 valent, and then a new hepatitis B vaccine with 3 antigens. Again, all codes that at the time the books went, they certainly could well have been approved since then. Anesthesia services. I mention anesthesia services because previously the codes were distinguished by knowing whether the procedure was a diagnostic or therapeutic. And so that created some issues. So the new codes now read image guidance injection, image guided destruction, and then on the next one, image guided neuromodulation. Now, what does that mean? Well, it tells you the difference between the codes, and then we simply have 2 levels of codes showing the location. Now, again, this is anesthesia the same day as a procedure, but done by a different physician. So if your doctor's doing the anesthesia, these are not the codes for him to use. These are the codes to use when anesthesia is doing anesthesia and surgery or pain management is doing their procedure. All right, so we had these image guided injection, image guided destruction, and then the last one is image guided neuromodulation or intravertebral procedure. So kind of a catch-all. All right, in the cardiology section, previously when we talk about doing an echocardiogram, we have different modes. So we have the old amplitude mode, and now we have the B mode, which has some brightness, and then the somewhat new M mode. So what we're going to do is take and make a 3D echocardiography image in order to visualize specific structures of interest. They talk about it being the surgeon's view of, for example, the mitral valve, and then it avoids some assumptions in calculating values. So here is an add-on code. So let's go through the symbols. So we got the hashtag or number sign, meaning it's out of sequence. Then we have a plus sign. That means it's an add-on code. That means you don't have to put a modifier on the procedure or on the E&M. And then the actual procedure. So the 93319. So we have echocardiographic image and post-processing during a transesophageal echocardiography or during transthoracic echocardiography for congenital cardiac anomalies for the assessment of cardiac structure, et cetera, et cetera. So this is an add-on code for this particular imaging. Basically, we're looking at visualizing the cardiac valve and any congenital anomalies. So here, this grid helps us to truly, I think, understand which codes can we use with each other. So cardiac ablation has seen a 100% increase in the last 5 years, 100%. And so they're looking at these codes. What they discovered is there were 2 codes that were billed frequently together, actually 2 sets, I guess, of 2. And so they're going to look at those codes and potentially bundle the services together, coming up with one code. And that's what they've done with this left atrial and the intracardiographic echocardiogram. So let me go to the next slide. I guess I'm getting tongue-tied, sorry. So here's our supraventricular tachycardia cardiac ablation. So here's what they do. 3D mapping, LA pacing and recording are now bundled, so that shows there's a code that's gone away. And this is a triangle, a blue triangle, meaning this text is revised or has been. Here's a ventricular tachycardia or VT cardiac ablation. And there's an atrial fibrillation ablation. Again, putting that 3D mapping and stuff are bundled in. There's a grid in order to identify services that are inherent to the procedure, that are bundled in the procedure, that are unbundled because it's only performed sometimes. So there is in your appendix information, always good information in your CPT book. Okay, interventional cardiology. We have this new to me, but a procedure for a central embolic protection device. It's like, well, what is that? Well, it's kind of like a little cup, if you will. If you know anything about TAVR procedures or TAVI procedures, you know, they go in and put a mesh work in the heart, in the pumping heart, so to speak. And so as they're in there rooting around, the chances of them knocking a piece of plaque or something free would potentially be deadly to the patient and could also have long-term negative effects for the patient. So this device is something that's going to capture what they call embolic materials, such as calcification fragments. So here are the guidelines, if you will, and it gives us lots of good information, placement of additional multiple filters. This includes remove of the filter, blah, blah, blah. So it spells things out for what we're looking at. And then at the very end of it, it talks about closure. And closure is not separately reportable unless there is extensive repair, which would obviously show in the documentation. And then here's an add-on code for transcatheter placement and subsequent removal of cerebral embolic protection device. So there's the code for their removal. Endovascular repair of an aortic coarctation. We have some codes. One of the codes is for the use of a balloon without a stent. Previously, we didn't have these codes at all. And we have more guidelines that we could look at, but this is just to give you a rough idea of some of these codes. Continuing to look at the rationale, we have 5 codes that were added. And basically, we're looking at this new code or new subsection that has its own guidelines and codes. And all of this was added to the program, if you will, in order to account for advances in treatment. And there's another grid that we have for the information. All right, otolaryngology. This will be an interesting one. This affects many offices: ED, primary care, internal medicine. When we look at the code for revision or for work on a nasal bone fracture, the guidelines are very specific in stating that we can't have fracture care without some type of service for the fracture. So it can't be without manipulation. It can't be without stabilization. Now, it's okay if you see a patient and don't do anything and send them on their way, but your time in and of itself with that patient is still a visit, and it's an E&M service. It's not fracture care. It's an E&M service. There's been certainly ambiguity, if they, as you say, in the language of the guidelines. So we have closed treatment that has no manipulation. That's called an E&M. We have with manipulation where you're just either pushing on the bone or you're putting an instrument up inside. And then we have codes for manipulation without stabilization. So another level, another layer, where we take either steri-strips to make like a cast for the nose, or we actually make an actual cast and put it on them. So making sure that if a patient comes in to see you, if they have a nasal fracture and all you do is an E&M service, that's all you bill for. You do not bill for part of fracture care. It is inappropriate. Again, so here are the codes. With manipulation, there's the phrases they use with stabilization, the phrases that they use. So here's our closed treatment of a bone fracture with manipulation, without stimulation, and with. And now we can talk about a drug-induced sleep endoscopy. So this is a dynamic evaluation. They're not looking at fixed structures, but rather they're looking to manipulate the airways and see what the overall structure evaluation is. There are some references here, and these references are for a nasal endoscopy, a laryngoscopy, and a nasopharyngoscopy. So you wouldn't want to have those procedures done and be part of this. Ophthalmology, kind of creepy with really good pictures. We have a code for a insertion of a drainage device. And so if you can imagine, and let me do the fast forward thing. If you can imagine, we're going to have the capability of putting in a medicine tablet or some type of dissolving entity right into the duct. Can also put a hard object, like a steroid or something, that may need to be in a sheath that would be disposable, but there may be a little cylinder. So all of this is they're putting this right into the eye. So now I'm going to go back to the codes. All right. So for this one, this is a new code for the insertion with an intraocular and anterior segment drainage device without some additional services. And then here's an insertion of an intracochlear, and yeah, boy, there's lots of big words this year. I'll let you read that word. So this is for the anterior segment aqueous drainage device without that extraocular reservoir internal approach that you did not necessarily want to use. If you use this one, you also have consideration. Here's some information about the T code and its code. So here is this trabecular place where they're putting some of the meshwork in. If this is the white front of the eyeball, and so this is sort of to give you a rough idea what the structures are. And there's that drug insert. And then there's also, again, some additional information about those. Insertion of a drug-eluting implant, including punctual dilatation when performed into a lacrimal calcaneus. So those are the I codes. Neurosurgery and spine. So we have a new procedure called a LITT, L-I-T-T. It's for laser interstitial thermal therapy. It's used for brain lesions. We have a code for simple trajectory, one for multiple trajectories. We know the rationale for these codes speaks to treatment of intracranial lesions, and it can involve the stereotactic placement of some kind of targeted lesion that we're looking for. When we look at arthrodesis decompression, there's a whole great big section. There's guidelines that have been revised throughout the spine surgery section, including new definitions within the word posterior, posterolateral, or lateral transverse process. Additional revisions were made to the relevant sections of the CPT manual to address some ambiguous terminology. And then we have illustrations have been provided to reference for people. Lost my train of thought, sorry. So what we have in these arthrodesis decompressions is we have lots of definitions. And this is done in order to, say this nicely, in order to make sure people are using the codes correctly. And also you'll see with these diagrams, area of bone removed during procedure. They're making it very specific, very easy to find which codes it is that I'm supposed to be using. So we have all these definitions. We've heard of lamina, we've heard of laminectomy. And so we go through this decompression, fascitotomy, I mean, there's big words, for single vertebral segment for each additional segment. So we want to watch when we're counting segments, how exactly it is we're supposed to be counting. It tells us that if we use this particular code with a laminectomy procedure, it prohibits the use of some other codes. So we want to be sure that we're doing appropriate coding in conjunction with other codes when we use these new codes. And then under this arthrodesis posterior and posterolateral or lateral transverse process technique, we have decompression performed on the same vertebral segment and or interspace as posterior lumbar interbody fusion that indicates a laminectomy, blah, 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 may be separately reported. So these are good parenthetical notes. I noticed they're not green, they're supposed to be. I can tell because of the sideways triangle that should be green because it's a new guidelines text. So here's the 2 codes for thermal destruction. And pay attention, this is for the first 2 vertebral bodies. And then we have an add-on code. That's what the plus sign is. And most of the time, these codes are created because codes didn't really exist for that type of procedure previously. Now, I want to take a minute and talk about what I call split procedure billing. I think there's another name for it, but I kind of like calling it split. I had a friend that was in California when she fell and broke her leg. She had surgery there, and then the next day they put her on a plane and shipped her back to Michigan. The surgeon should only have billed for the preoperative management and for the surgical care because he was never going to see her. Not only not see her postoperatively in the hospital, but he was not going to see her in the office. And so the appropriate way to bill that service would be for him to bill for the preoperative management and then the surgical care only. And then the doctor here in my town would bill for postoperative management. It's not whatever happens, but it's the way it should be. Now, I mention these because there are modifiers to identify the 3 different parts of the services so that on a given procedure code, it can be identified as being part of this surgical split billing. So when we look at a whole section called restorative care, we have introductory guidelines that have been revised, words that have phrases that have been changed. When we look at the fracture and or dislocation treatment, we have a new subheading that's been added. And then it tells us that there is no correlation between the type of fracture or dislocation and the type of treatment. So as we look at the codes, we have to look with a different critical eye. So here are the treatment definitions that are offered within this section. And then just some rationale. The one to remember is this closed treatment, and is your office, if you're not ENT, providing this emergency or this type of service, if you're just a regular office, that if you have someone comes in that has a broken wrist, sorry, I was confusing my noses and wrists. If you have someone that comes in with a broken wrist or comes in with a broken arm, or you think it's broken arm, we have to look at, is this really close treatment if we're just putting something on it to send them to the next person? Because we're not really manipulating anything. We may be just putting some kind of a casting or strapping on it. So as we look through this section, we want to be sure we pay attention to the type of treatment, the type of stabilization, so that we know within the codes what the differences are. And then under reporting of fracture or dislocation treatment, the physician or the qualified healthcare professional providing the fracture treatment should report the appropriate fracture dislocation treatment codes for the service provided. If the in-person providing the initial treatment will not be providing subsequent treatment, a modifier 54, surgical care only, should be appended, which I have I think, one time seen these modifiers used. It's the way we're supposed to do it. It just doesn't always happen. Continue on this cast and strapping guidelines. All services that appear in the musculoskeletal system include application and removal of the first cast. Then after that, we have to go to the rules to figure out what we're doing. Under radiology, CT of the heart. So we have several editorial changes in order to sort of be equal when we're trying to look things up so that there's more clarity. And also to provide, as we look at this confusion that we may have had. So here's this revision code. We know it's a revision because it's got a upside down or an up and down vertical triangle that's blue. That tells us it's revised. And then we move on to trabecular bone scores. So a TBS is a measurement of the structural condition of the bone and its microarchitecture. It's different than bone mineral density or DEXA. And they can look at if someone has a high TBS value, it means that this microarchitecture of the bone is dense and well connected with little spaces. If we have a low TBS, it means that microarchitecture is incomplete and poorly connected. So it allows for diagnosing of issues. And here are some of our TBS codes. Our parenthetical notes, don't report these with those, et cetera, et cetera. There's a code for a percutaneous ultrasound guidance gastrotomy tube placement. This one just made me shiver a little bit, so I think that's why I included it. This is only for use with the percutaneous ultrasound guided gastrotomy. And so there's a very simple code. Under thyroid nodule, thyroid nodule laser ablation. It's a new minimally invasive outpatient process or procedure compared to a traditional open surgical one. It says it's reported multiple times in a session, no matter how many nodules. Reported one time, no matter how many nodules. And that's because of that parenthetical S here. Anytime you see a code like that, that means 1 or 100, just that one code. These are the category 3 codes because of the T. So they are looking to be used and utilized. And then here is a new ultrasound. It's a quantitative look at the information as the beam comes back. It allows them to look at liver and look at fat content, or in the breast or in the eye. It allows them to make a determination about whether or not there's a problem with the tissue. So let me go back one. So there's one code obtained without diagnostic ultrasound, obtained with diagnostic ultrasound. Sorry, I am getting so tongue-tied. And then this is a code that I think is kind of cool. Fluorescent molecular imaging of skin. We have new codes. Again, they're temporary codes or T. So these 2 new ones were suggested. The first dye is applied to the lesion, and then a bunch of images are taken. And finally, the images are transferred to a computer and analyzed with a written report, and it says is required. So going through, you've got to have a physician at some level. So here's the first lesion code, and then each additional lesion. Lab and path. We have a new, well, kind of new, it's revised, but it's new. Clinical consultations for pathologists. What in the world is that? Well, we have a request that comes in for a pathologist to review the path and lab tests. There are requirements for how to do this. I think currently we have I can't say that. These pathology consultations, as it says, are in response to someone from, for example, primary care office or another specialist office. And it says that there's one relevant clinical or diagnostic information as we're looking for it. We're requiring additional medical interpretive judgment. And so basically it's a consult. Now, one of the things I want to point out with the consult, as we look to, we know we had the changes to E&M office and other services, offices and other outpatient services for 2021. We know in 2023, other codes are going to change. And I think what we're seeing, and it's my opinion, is that some of these language changes in places are to better affect when we get to 2023 and things start to really change. So selection of the appropriate level may be based on either total time or consultation time. And then here are the codes. So we have a 80503. So here's a limited review in 2, complex. We have a moderately complex clinical problem. The 5, highly complex clinical problem. And then we have some listing with some information on prolonged services. We do have a grid. Notice it says elements of medical decision making, and it does look a little different. We have 1 or 2 lab or path findings here, so that's a little different. And then here is our second page. So this level 4 consult, you can see we've gone from just a couple things to several things in these columns. But most of the columns are exactly as we see for the 2021 changes to office and other outpatient services. And they're going to use time the same way. Here's a list of things that we can say are associated with time when we're looking at time when it comes to these services. And then we have a neutralizing antibody test. It's the only test that's been approved to see whether you have functioning neutralizing antibodies. I'm not sure what the technology is for. We don't know how widespread this is going to be used, but there's at least one of them out there. The COVID-19 neutralizing antibody and quantitative antibody testing. And then information as we go forward on some of these agent antigen detection team, if you will. And there's some codes. And I only put these in because they have to do with SARS. Not necessarily something you're going to use. File it in the back of the brain in case you need it. And then we have some proprietary lab tests. These are lab tests that were developed and are recognized as being the authors for these tests. That means if this test is ordered, you're still going to have to be working in conjunction with that school in order to get the results of the test, but at least the tests are out there, and there's lots of interesting material in the test material, if you will. Here's some more of these U codes. And then I'm going to just take a couple moments here because we got time to talk about split shared visits for 2022. And I say that because they were talked about at the AMA meeting. Now, if you think about what you know for split shared visits right now, we know that split shared visits can't be done in the office, and we mostly do them in the hospital setting. If you go to the physician fee schedule final rule, which comes out in November, it's about 2,700 pages right now. Well, there's about 35 or 40 pages that are on this singular topic, and it has a bunch of definitions of what things are. So that would be something you can use to go look it up. And then even within some of the subsections, there's additional sections. So basically, the CMS E&M guidelines talk about a split shared visit in which a physician and other qualified healthcare professional each provide some of the care. We have time personally spent by the physician, other qualified healthcare professional in assessing and managing the patient is summed. Only distinct time shall be used. So they are, saying, okay, here's the guidelines that we have for split shared. And for those of you that didn't notice, they pulled this information out of, I believe it's chapter 12, section 30.6 something in the Medicare Carriers Manual. They pulled that information out in order for them to make changes to it. So if we have a physician that wants to bill a split shared visit, they can only do it if they perform a substantive portion of the visit, they're in the same group, furnish the visit in the same settings, and are furnished in accordance with applicable law and regulation, including conditions of coverage, blah, blah, blah. So that's how we're supposed to do it. So the biggest change is we're looking at this substantive portion. Substantive portion, if you go into the Medicare Carriers Manual, in one section, the E&M section, it says, okay, it's just a face-to-face portion of the visit. So the doctor can stick his head in the room and say, hey, and that would be good enough. Then another section, the nursing home section, says, well, no, you can't use that here, but if you could, we'll define it for you. So that was kind of a tricky thing. But as we look at those two definitions, they're not going to work well, because when we talk about office and other outpatient services, E&M services, that other E&M services, the office and other, so the second one, as we go forward, they're not going to have the element of history and exam to deal with. And so they're not office-based, they're other outpatient services, so they're going to come under some different rules, and that's wreaking havoc. So the split shared policy for 2023 was modified for 2022. So the practitioner who's considering to have performed the substantive portion spends more than half the time and performs the history exam or medical decision making. And then here is examples given of all the variables you can have from the questions on the previous page. When we look at 2022, so they're going to allow history exam or medical decision making or more than half of the total time. And this is included for emergency department visits. How do we come up with that time? We have to make sure that as we're looking, and I haven't forgotten about that question, how do we come up with time? We know documentation in the medical record has to identify both of the practitioners who perform the service. And then they recognize that this would policy would necessitate the practitioners tracking and documenting the time they spent for visits. So we have some stress, if you will, on physicians supposedly in keeping track of the time they spend on things. So for 2022, we have one set of rules. For 2023, we have another. Makes me have a headache. But here's a great little grid if you understand it. And here's our office visits that will not be performed as a split shared visit. And so I would ask for clarification when we're looking, is this a regular office visit or is this an other outpatient visit? Are you a facility-based clinic, in which case they're not office visits, it's an other outpatient, because it makes a difference in what you can and can't do. Again, remembering that for 2022, because where we are in this transition with the E&M services, we can go ahead and use the history and exam or medical decision making, or use the time method. Once we get to next year, it's all going to be about time.